All right, welcome back to another exciting episode of ORTHOStatic, the podcast from the Academy of Orthopedic Physical Therapy. Today, we have a guest who's as dynamic as he is distinguished, hailing from the land down under. He's made his mark in Australia, Canada, and now here in the United States. Not only an associate professor at the University of Florida, but also a leading light in the management of musculoskeletal pain. When he's not shaping minds in the classroom or mentoring PhD students, he's unlocking the mysteries of pain through manual therapy and exercise. Let's welcome to the show, Dr. Mark Bishop.
All right, thank you very much.
All right, we'll get the hard questions out of the way first. We'll give you the nice broad one. Mark, what's manual therapy? That can't be a simple question, or maybe I should say it's not an easy question. It's a simple one, and then we'll back it up. But why is it important in this area of orthopedic physical therapy? How would you answer that one?
Well, manual therapy is a group of ancient techniques, actually. So with thousands of years of history of people performing manual therapy interventions, which essentially are skilled interventions for which you and I use our hands to deliver some sort of treatment. And so historically, we look across multiple different cultures and multiple different eras. There's always been manual therapy as part of healthcare and like health improvement. I'd say the more modern definitions that you'll read about is like series of skilled passive movements. So types of things where I'm using my hands to perform very specifically goal-directed activities, and those can be directed at the joints, the muscles and soft tissues, neurovascular bundles, kind of broadly, and they're used mostly to manage neuromuscular conditions. And I'd say that one of the definitions I really like about it is that it's an approach that uses clinical reasoning, highly specifically directed treatments that include both manual techniques with my hands combined with exercise. And so for me, that's the definition I like the best for this.
Yeah.
And I think why it's important, we certainly, you talked about tangents before, we can go off on plenty of tangents. I think that one of the reasons that manual therapy is very useful as a system is that it's a systematic approach for me to deal with someone's neuromuscular health condition. And for that reason, I think, in my opinion, is the approach is important in orthopedic PT. We can certainly debate, and I know there's plenty of debate about which approach is most effective, but for me, the systematic application of manual interventions and exercise has been effective in my career, and I think overall effective across pain in particular, but broadly lots of different orthopedic conditions.
All right, so next question is, how does it mix? How does it play well with others? How does manual therapy integrate with other treatment modalities, or should it be all or one?
Once again, you get plenty of debate here. I would say that I think it has to be integrated. It's not a standalone. Certainly, my preference, Mark Bishop's preference, is I trained in a manual therapy system, so that's my original bias for thinking about how we look at how you're moving, what is happening. So I use my hands a lot for that, but when it comes to actually intervening, I certainly may do some manual techniques, but it has to be part of the bigger picture. So it has to include things related to other systems, movement systems, cardiovascular system, as well as a bunch of other things. So you have to do the manual therapy part in conjunction with the exercise. You may include other modalities in there. I personally don't use a lot of other modalities, but certainly it has to be combined with everything. I don't know of any examples where it's just effective only to do the manual therapy part for broader recovery. I might just be able to do a manual therapy intervention and make some sort of change, but I don't think that's going to help the broader recovery of a health condition.
Yeah. Now, if you ever looked or try to find misconceptions, you don't have to go very far, because people will take something with this internet thing that we have, and typically it'll be like a game of telephone. So what are some misconceptions about manual therapy that you come across? And then, what would you say to those things? What are the frequently misconstrued ideas?
Well, I'd say probably first and foremost, one of the things I think is that you have to be very, very specific with a particular biomechanical model to be effective. I think that's a misconception. Certainly, a lot of our historical theories about how manual therapy may actually improve someone's health condition were based on very complex biomechanical models that, as they've been studied, haven't necessarily stood up under all circumstances. So the idea that I have to very specifically push or move something in a very specific direction at a very specific frequency may not actually, in fact, be true. I think another misconception is that one particular system is better than another.
Yeah.
I don't think we've seen that either. I think that when I have looked more broadly at systematic approaches, and by that I mean, doesn't matter what system, if I'm an advocate for a McKenzie-based system, a mechanical diagnosis and treatment system, or a Maitland-based system, it's the system that's important. Not necessarily the specifics of the technique, but the more systematic my approach is, the more likely I am to get a comprehensive picture and make a good decision.
Yeah. Well, with that being said, it sounds like there's no one best, but it's better to have a process and follow that process. So I was going to say, what are some of the best trainings required in your mind to perform manual therapy effectively? But it sounds like I don't know if I should even ask that question, because it sounds like the answer is it depends, which we love in PT.
I think it does depend, and where I have ended up on that personally is that we in our own research have done a few things that indicate that there's an intersection between what you want as a patient, what you prefer, what I prefer as a provider, be that manual therapy, be that exercise, be that whatever. And there's an interaction that occurs when these things happen that helps improve outcome. It's not responsible for all outcome, but it certainly helps improve the outcome. And so the way we kind of interpret that is the type of system that I endorse is perhaps not as important as how much I've practiced that system. The relationship that develops between you and I as patient and provider, in part, is driven by your perception of my competence. Your perception of my competence is in part driven by my self-efficacy and my confidence in my ability to do an exam and do an intervention that's going to help you. That confidence comes from practice, regardless of system. So if I find a set of techniques or a set of interventions, a philosophy that I really endorse, then it behooves me to study that well, become good at that system. That improves my confidence in that system, which then helps drive your perception of my competence and helps build these interactions. So that's kind of where I've ended up, that as long as I endorse a system and I've practiced that, then that's going to improve the outcomes that we have. And I think as I have talked to other people, that certainly there's not many people just in my circle of acquaintances and peers that endorse just a single system.
Right.
There's many of them that will use elements of different theories and philosophies. They practice those, perhaps trained with the developers of those, and become confident in using them. So I think I kind of danced around your question there about, is it one system better than another? I think you just choose what system that you really like and get good at that by studying and practice.
Now, most of what we've been talking about is ideas and concepts. but is there this is all around people, right? I mean, you study these things to be able to help and make a difference in people's lives. Is there a particular case? Is there something that comes to mind where if you had to show the benefit of manual therapy and the techniques you've studied has made a significant difference? Is there something that comes to mind that you could actually put a face to?
There's a couple. There's a couple. I'd say when I think about this, the person that I remember the most, that's part of the bias with this sort of recall stuff, is I remember the people who did really well. I remember the people who did not do well. And there's a group in the middle that I don't really remember. But a person I remember doing really, really well had headaches and orofacial pain, and we were doing a few things. And then it wasn't until I did a upper cervical manual technique that that particular person experienced, or at least reported, great relief to the orofacial pain. And I remembered that happened decades ago, and just remember that sort of person getting up off the table and say, "Ah, that feels so much better." We went on to do lots of other things, but it was just that particular technique that we did, I think, met a bunch of different needs and caused a big difference. Another person, if I may, that I remember a lot is a colleague of mine had, I don't know, long-term neck and thoracic pain, and she got some shoulder pain, and she'd been going to see some people for a set of interventions that weren't working for her. And I had the benefit of her telling me, well, I've tried this, I've tried this, I've tried this. And so I could say, well, we won't do those because you've tried those, let's do this. It turned out it was some simple sort of assisted movements, some thoracic PAVMs, some passive physiological motion. And she got up and said, oh my God, that's the best I've felt in months. And so those two stick with me. But like I said, that's a big recall bias. But they're two examples that people found really good immediate short-term relief, and then didn't need a lot of follow-up manual treatment after that, and we were able to move into doing other things.
Now, Mark, you work with students, and students always come with a lot of these things called questions and insecurities. If they're still listening right now, if you've got some either students or new grad PTs in the first 3 to 5 years of their career, where would you send them to start? They've got to start somewhere. You mentioned finding a paradigm, and the goal is to find something that works for you. Doesn't necessarily matter what it is necessarily, but where would you send them to start? What would your suggestion or advice be?
I'd say to a mentor or a senior PT at wherever they're working. Talk to that person about what works for you. How did you make those decisions? Why did you choose that? And then the next step is to learn a few different things. I'd say my own journey, if I may, we studied in Australia, and our focus was on Maitland-oriented manual therapy techniques. And then I had the opportunity to go and work in Canada, where the techniques were different, and they were doing a lot of post-isometric holds and movements and some muscle energy things. And then came to the United States, and there was a whole group of soft tissue mobilization things that I had never encountered before. And so I took some of those courses. I'd say over that couple of years, I found my favorite. My favorite stayed with my base training, which was the Maitland, and stuck with that. But I think if you have the opportunity to try a couple of different philosophies, can find one that conceptually says, that makes a lot of sense to me, then that would be where I would get you to start.
Yeah. That's a pretty big difference, right? That's international. I think a lot of the PTs, especially in the United States, aren't necessarily exposed to that. It sounds like you might recommend that because it's so different.
Recommend it? I think I would. As philosophically, the Norwegian manual therapists are going to think a little bit differently from people who have developed their own system here in the United States versus the osteopathic origins of, say, Grieve or Maitland. And so each of those comes with a different set of sort of background philosophy that we can debate about the accuracy of those, but their approaches are then a little bit different for how they do the techniques, combine the exercises with those techniques.
And then you sort of find, it sounds as if you're saying, then find the things about those varied things that they align with you, work for you, and that's how you find your own skill set.
Absolutely. I think, Stanley Paris did a lot for manual therapy in the United States and has some great courses if people are interested in sort of joint focused things here in the United States. That's somewhere they could start. Certainly the Norwegian PTs have a presence here in the United States. The neurodynamic approaches, Dave Butler and others, kind of thinking about neurovascular bundle as a potential source of these type of things. Those are all available here in the United States for people to try.
Last thing we do on OrthoStatic is call Words of Wisdom. Is there something you want to leave the audience with, either a soapbox statement or something that you use as your mantra? What do you want to leave with the audience as we exit?
Care about your patients. That's what I think. I think if some of our outcome is related to our relationship, then it behooves me to think about that relationship and truly care about the person in front of me. I don't know if this resonates with anybody, but I can tell if I'm not into it, if I'm maybe not having a great day or don't feel like talking, then my outcomes that day are just not as good. I don't feel good at the end of the day. The people I've seen don't necessarily feel as good. And so if I can just focus on being present, care about the person in front of me, then that goes a long way.
Yeah, great words. Dr. Mark Bishop, thanks so much for stopping by on OrthoStatic.
You're welcome. Pleasure.